the Community Assessment and Education to Promote Behavioral Health Planning and Evaluation Project. And it's my pleasure to introduce our speakers today. Gerald Dukeson is Director of the Community Health Needs Rural Health Works there in Oklahoma State University, and Cheryl St. Clair is Associate Director of the same center. And with that, I think we'll just turn it right over to you so we can get started.
Good morning. I'm going to do the about the first half of it, and then Cheryl's going to jump in, and then we'll have time for questions. So good morning to you all. It's a very cold morning in Oklahoma compared to us, but a number of you are, I'm sure, experiencing much colder weather than we are. We'd like to share with you today a model which we've developed for community health needs assessment. And we're just going to give you an overview of it. And the reason I suggested this to Scott was there's a lot of things in this community health needs assessment process that can be easily adopted or modified for a community behavioral health assessment tool. And because of that, we decided to do this webinar and to share with you exactly what's in it and how it might be modified if it wanted to develop a community behavioral health assessment tool. This particular toolkit was developed because of it's required in the Affordable Care Act that nonprofits conduct a community health needs assessment every 3 years. And that was the emphasis for developing this, even though our center had other assessment tools, but we modified it so it could really be used to meet this new requirement. And we had a national committee, and on that were people from the American Hospital Association, the National Rural Health Association, Office of Rural Health Policy, and also 2 local hospital administrators, as well as other people around the country. It's currently being used in many states, and Kansas, I know through John Leatherman, has adopted a version of this as an example, but I'd say 30 to 35 states are using some version of it to meet this new law. The community health needs assessment process involves, when we start working with a community, and it's designed for a rural community. It involves identifying 30 to 50 community leaders and representatives that serve on a community committee. And I must stress right up front that we really, when we start this process, really make sure that all segments of the community are involved. If you have a Hispanic portion, if you have a Native American portion, that all segments of the providers as well as the residents are involved. And I'll explain that a little bit more in detail in a second, why that is so important. We designed a process that can be done at 3 or 4 community meetings. Now, we encourage it to be ongoing once it starts because the law says it has to be done every 3 years. We have found in most rural communities, we'll meet when the people want to meet, but if a lot of times noon works out the best. And if you provide a lunch or a light lunch, people will come. And normally we really respect their time because these are the leaders of the community, and we strive to get it done in an hour. And we really stress this, and it works out very well. The facilitator of this could be a local community member, Chamber of Commerce, hospital administrator. Sometimes when the hospitals do it, it's their marketing person. Or it could be a professional from the Extension Office or the Office of Rural Health, or maybe even an AHEC. It's important that you have to have a good facilitator. And sometimes the outside person works a little bit better, but we have a lot of people from Extension and the Office of Rural Health around the country doing these. There's work involved here because we develop products in preparation for these meetings. And the committee's job is to review these products, design them, and come up with a health plan. Now, to share the process, we are going to go through the 4 community meetings that we have and just illustrate the products and the process. The first thing that we do is we conduct an economic impact of the health sector. Now, this is not mandatory, but I find out it is very, very useful in documenting, quantifying the importance of the health sector in a rural area. And it always is much larger than people think. So even though it's not mandatory, personally, I would not do an impact study I would not do an assessment product without an impact study. For this webinar, we chose a community that I've just finished working with in Maui. And you're going to say Kula Hospital is not rural. It is very, very rural. It's located on Maui, up in the mountain in the rural area. Has the very, very typical problems that any rural community in Oklahoma or Michigan or Iowa would have. It's very, very small. You can see where the star is there, and it is sparsely populated up there, and it has the poverty and all the problems that you would experience in a rural area. The primary medical service area there is about 10,000 people, and this particular hospital has a clinic and it has a nursing home. They have 2 doctors in the clinic, which illustrates the size of their medical service area. Their employment is 217, their payroll's over 17 million. And we also look into the impact of construction on the economy, and there's the construction expenditures for the last 3 years. For 2012, using M-Plan, we estimated that created 8 jobs with a payroll of 476,000. To illustrate to the community, I use this, and I'm illustrating the concept of multipliers. I use this triangle, and as business occurs outside the triangle, of course, you lose your economic impact in the community. And I use this particular figure to illustrate multipliers. The triangle here is, in this case, is the medical service area, which is zip code devised. Those of you that have worked with M-Plan know that you can do zip codes, counties, and so forth. So that is what we use. This is the economic impact that result that we got for running the model. The 217 jobs. The medical service area has a multiplier of 1.39. So the secondary impact is 85, and the total employment impact is 302. And we can also do that for construction. So the bottom line for 2012 is there were 225 jobs created directly, 88 secondary jobs for a total of 313. We can do the same thing for income, and income here is defined as payroll. So the $17 million in payroll, the income multiplier is 1.22, secondary impact of 3.7 million for a total of 20 million. So, and the bottom line when we add construction is the direct payroll impact of 17 million ends up being 21 million when you include the secondary. The bottom line of this report is to really zero in on illustrating to the community how important the health sector is to them economically. And those of you who use an M-Plan know that you can break the health components down into narrower ranges. You can look at hospitals, you can look at nursing homes and assisted living, you can look at doctors, and you can look at home health care. So there's 5 different components in M-Plan, I think 6 different components in M-Plan that are directly related to the health sector. The second thing that we do at the first meeting is hand out Community Health Needs Assessment Survey. And on this survey, we zero in on where people are getting services and why. So if they're not using local primary care, if they're not using the local doctor, why? If they need specialists, which ones do they need? Now, I'm not going through this survey with you all, but I wanted to illustrate it because we have found the method we use to be very effective and inexpensive. We were doing this by a telephone survey, and that's getting almost impossible with cell phones and so forth. So what we have adopted is a method where if we have 30 community members involved that represent the community, we ask each of them to get 5 completed surveys, and that converts to about 150 completed surveys. And that has worked very well, but that is why that committee needs to be representative of all aspects of the community. If you're having a community meeting and you know that a minority is not on the committee, wait a minute, 10% of our population is that minority. We need to make sure we get equal percentage from that particular segment. Now, in Kula here, they combined this with the Survey Monkey, and it works very, very well. And just got to be careful that it is representative of the community, and you can ask a few questions on there to make sure that it is representative. But with the how expensive telephone surveys can be, this works out to be a very inexpensive way of getting community input. And you can see it's generally about 2 pages front and back, so it doesn't take people too long to complete it. In summary, for community meeting 1, we have a discussion of the economic impact study, and we have the discussion of the community health survey as we pass it out. And generally that's a hour-long meeting, but again, I stress the economic impacts study is very important to have those community leaders realize that health can be a large proportion of their employment base, and in fact we find out in rural areas a lot of times it can be 25% of the employment base. Now Cheryl is going to talk about what we do at
For community meeting 2, prior to the
Cheryl,
meeting, we have 2 data reports prepared. One of them is on the demographic and economic data for the medical service area, and the second report is the health indicators, health outcomes data report. These reports are the attachments. I'm not sure how those attachments get to you, but we attached all of the products that we prepared for Kula. So there's an economic impact report, there's a copy of the survey, there'll be a copy of these 2 reports also in those attachments. If you want to look at them in detail, we're just giving you an overview. So on the demographic and economic data report, I just put in a couple of tables on population by age from the Census Bureau, and we put in 2 slides, one for the 2000 census and then one for the 2010 census, so you can see how the area is changing in terms of the age groups and the total population. On this was a zip code area because the counties are quite large in Hawaii, and Kula is that last zip code there, the 96790/96788, and it has not quite 10,000 population, only 8,000 on this second screen if you look there. This particular table also shows how the age groups are changing and how our elderly population is growing. We include a lot of other data in this report. We just put in 2 tables to illustrate, but we have other census data on the population in general and how it's changing, population by gender, and we also show population by age, race groups and ethnic groups. We add into here the U.S. Department of Commerce Bureau of Economic Analysis tables. We also have tables from several other sources, so that in the U.S. Department of Labor, so we can show employment, unemployment, and so forth. So we put a lot of information together here to show what's going on in that community in terms of the demographic and economics. The next report is the health indicators, health outcomes. And we've tried to find as many national sources for this. And in this particular one, I have a sample from county health rankings. And I don't know if anybody else participated in a county health rankings webinar on, I think it was the 14th of January. And I did, and this is from their data. We find it very, very useful that County Health Rankings and Roadmaps program is a collaboration of the Robert Wood Johnson Foundation and the University of Wisconsin Population and can't remember the name of it, Population and Health Institute. And they have data for every county in the U.S. and it is very useful. And if you haven't participated in their webinar, even though I've been using their data a long time, I learned a lot from their webinar in terms of how their roadmaps works and how it can be used in assessing a community's health. So you may want to actually get in and look at county health rankings more. The other data that is included on this report is typically from the state agencies in the particular state you're working at. So it varies from state to state. A lot of the data is typically from the State Department of Health or their Department of Mental Health. And so you'll include as much data there as you can also, and that again varies by every state. At the end of the second meeting, after we've gone through all of the data on those two reports, then we discuss the data from those reports and try to get their idea on what they consider the health needs of the community from those two reports. Then we go into community meeting number 3. At community, I should reiterate, although we didn't put it on the chart, we have the community committee take copies of that health survey that Gerald shared with you, and we have them take it to 5 to 6 people that are representative of the part of the community that they represent, whatever the constituents that they represent. And we have them bring that back at community meeting number 2. So we pick up those surveys, and then before we have community meeting number 3, we have then analyzed and aggregated that community health survey data, and we're ready to present those results at community meeting number 3. We also present a primary care practitioner needs assessment study, so they can look and see if they have enough primary care practitioners in their medical service area. The survey results, that survey I think was about 20 questions, and I just took one of the questions here that showed the satisfaction level with the care received at the hospital and why they were satisfied, and we try to put bar charts, pie charts, so these are easier for the community group to look at and to see the results. But you can see there shows, you know, they had quite a good satisfaction rate, by the way. This was the number that were satisfied. That was 180 responses. And then on the next slide, it's how many were dissatisfied, and there were only 2. So it really is very, they were very happy with the results there. But it shows why the people like them, you know, the staff, the professional, friendly, qualified staff, quality of care, and so forth. But we put all 20 of those questions on this results report and share it with the community, and then we also presented to them an analysis of the demand for their primary care practitioners. This is a report that we have done quite often, and we do it for almost every community that we work with, because a lot of times when they come up with their community health needs, they'll say, well, if we just had more doctors or practitioners, you know. And so we said, well, let's determine if that's truly what you really need. So in order to determine that, we need to look at the population of the medical service area. In terms of CULA, we had a primary medical service area, and we had a secondary medical service area. The primary medical service area for the 2012 population, which was the latest population estimate available when we did this study, shows a total population of 10,000. If you look at that table, the first column there shows the male population by age groups, and then it shows the visit rates. Those visit rates are from a national source, and they show how many visits on average a male under the age 15 goes to the primary care doctor 2.8 times per year. When you get up to the age 65 to 74-year-old male, they see the doctor an average of 6 times per year. by using those averages and applying to the population, we can look at how many total primary visits. We can also do the same thing for the females in the secondary area. For that primary medical service area, we have 19,921 total visits to physicians. And actually, I'm saying this wrong. That 19,921 is all office visits. The 35,894, excuse me, is all office visits. And then 55.5% of that is to primary care practitioners, and that's the 19,921. And we do the same thing in the secondary medical service area. All physician visits they go to are 94,232, the total at the bottom there. But the number that go to the primary care practitioners is the 52,299. And that national source that we talked about, it shows that 55.5% of those total office visits go to primary care practitioners. Now the next chart then shows us, converts that back to how many doctors. So we use a usage rate for the primary service area across the top there and for the secondary area down at the bottom, and we used a total of 95% of the primary service area residents used the local practitioners, and we used 40% for the secondary. So if you go across there, and it's kind of bolded, it's hard to see, but it's bolded, there's 39,845 visits to primary care physicians, both within the primary and secondary service area. Then we use a total of 5,000 average annual primary care office visits per physician. So when you apply that or take that 39,845 visits and divide it by the 5,000, you can see that we have a need for 8 primary care physicians. And that can be converted into mid-levels or other practitioners, but that's 8 physicians. Now they actually gave us a list of their physicians on the next slide, and they actually within their service area only have 5 primary care physicians and or mid-levels. Now that they're all physicians there, and so they are short on the number of physicians. At the end of community meeting 2, then we let them do a discussion of the results of the community health survey in terms of what they consider to be the needs of the local community, and a discussion of the primary care practitioner needs assessment study. Gerald, I'll let you take over meeting number 4.
I'm going to talk about meeting number 4. Meeting number 4 is basically discussion and listening to them. Then we start out by having flip charts up in front and present the highlights of their discussions that they've had on the data that's been presented at the other meetings, and let them continue to discuss. So at that point they'll have highlights of the demographic and economic trends, they'll have highlights of the health indicator information, and then they'll just have seen the survey results. So again, we'll put those up, and then we'll just let them discuss as to what are the 3 to 5 highest priority things that they have seen in there. And generally, I've never had any problems where by the time they've discussed 30 to 45 minutes, they have narrowed it down to these are 3 to 5 things that we consider high priority. These are how we will address them, and then we in this case, Cheryl and I would help them write their plan. And the plan that we wrote, you also have as an attachment, but there will be a summary of the 4 reports, and then the actual things that they wish to do. And I haven't presented any of those in the overlay, but I think it was interesting that they had, and I'll give you a couple of the things that they identified and some of the things that they were doing. But community leaders are very, very sharp people, and they see a need, and they can come up with strategies that sometimes I wouldn't think of. One of the very highest priorities that they had in this particular community was immunizations of their elderly. And the data from the health indicators, uh, and that health indicator data was very good, showed that at least 60% of the elderly were not getting flu shots. And that is just very, very high uh, compared to anything. Likewise, they weren't getting the pneumonia shots and so forth. So the immunization thing was very high on their list as ways to address. And it was interesting. They had a student nursing program in that area, and the next thing they said, hey, we can have the student nurses travel with the Meals on Wheels and educate the elderly as to the importance of the shot, and if possible, if things get done, they could likewise probably do some immunizations through that particular program. So that's just an example of how the community can respond to some of these health needs. Another one was that kind of surprised me was
Seem to have lost audio from Gerald. Let's see. Well, looks like our presenters are. Oh, yes. Did he get downgraded? Okay. Let's try again. There's Cheryl. Okay. Gerald, we lost you for a second there. Not sure what happened with that. Doesn't sound like he's back. Well, this might be a good time for some of the others on the line to type in some questions that we can get addressed once we figure out these technical issues. So if you've got questions about how they approach this, this would be a great time to put those in to the chat box. Not sure why the sound has suddenly disappeared.
Scott, can you hear me?
Yes.
Do you
You're
want me
back.
to go ahead and finish it real quick?
Yep.
Okay, so we have the community group address all the issues from all the reports that they've reviewed, that we've reviewed in the first 3 meetings. Gerald's not on, so he said for me to go ahead and finish and prioritize those, and then they make recommendations on how to implement or how to develop an action plan, and then we help them summarize the community health needs and their recommendations in terms of what they think they might be able to do as a community, and we then give that back to the hospital. The hospital takes those recommendations and that report back to their hospital board. The hospital board has final authority as to what's going to happen and what they can do with that, because they obviously have to deal with what resources are available to deal with any of the community health needs issues. After the board reviews that information, then they develop a complete full-blown plan as to what they will actually do with the recommendations from the community committee. So 2 reports actually result from this community health needs assessment. One is the community health needs report from the committee, and the second one is the actual final report and action plan that the hospital board determines that they will be able to do. At the end of that first community health needs assessment process, we encourage the committee to meet again to address actions and enact the plan. This plan may not just be the hospital enacting it, could be many other organizations working together. So they may already be working with some of those community members. Again, they're required to do this every 3 years. So during the 2 years, the interim time before the next plan is due, they are working on the community health needs issues that they determined were in need and on that action plan, and then they get ready to do another plan in the 3 years later. The purpose of us presenting this community health needs assessment toolkit to the CAPE audience is that we felt like this might be a process that could be adopted or modified for a community behavior health assessment tool. So we thought that might be useful. And our complete toolkit is on our website. You have a copy of an entire process through Kula Hospital. You have all the products there, and you also can go to our website, and it explains how to do the entire community health needs assessment process. And now we're open to any questions.
Well, great. Thanks, Cheryl, and Gerald too. If you can hear me. Um, the materials you sent also will be on the healthbench.info website, so the example reports and such will just live right alongside of the webinar archive that we're recording right now. And Dee had a question about the multipliers. Cheryl, you want me to handle that, or are you
You can.
comfortable
No,
enough to handle that?
I'm comfortable. You obviously know as much about it as I do, Scott. Go ahead.
Yeah, yeah. Unless I'm misinterpreting things, they use a software that's very standard in regional economics called IMPLAN. It's an impact analysis for planning, and that's it's a, it's a, it's a, it basically will tell, based on some national ratios of how things play out nationally, scale down to that community, how, you know, shocking the local economy by putting a new one in or taking the existing one out, how that will change, how that will ripple through the local economy. It's a very standard technique that's used in economics for these kinds of questions.
It's from Implan, yeah, Implan LLC. It's available at the zip code level or multiple zip code levels is what we use for Kula. You can do one county or multiple counties, one state or multiple states, and there's national data available.
Yep.
Okay. Any other questions?
Yeah, I was interested in thinking how much detail can you get in terms of I mean, you're talking about the total health system on those impact reports. Can you drill down and to talk about mental health services kinds of things as well, or does it have to stay at that more aggregate level?
Well, what we use it for, it's actually the not-for-profit hospitals that are required to do the community health needs assessment, and they are reviewing the needs for the overall community in terms of overall health. You're right. Our thought was that you could present just the data concerning mental health or behavioral health and have a smaller, maybe only one or two meetings, and have data on the behavioral health and have the community assess just behavioral health in terms of this project. Did you have anything else, Gerald? That's what Gerald said. Yeah, that was our thought. It looks to me like too that University of Wisconsin Population Health Institute and the Robert Wood Johnson's has the roadmaps that also encourages a community to look at their health indicators and health outcomes and to determine how to reduce those. And I noticed that the National Rural Health Association meeting the end of April, there is a community that has gone through that county health rankings and actually used that to reduce some of their health indicators and health outcomes. And there's going to be a presentation there, Scott, on that. I thought that would be an interesting one for the group.
Yeah, good. Did you see Steve Miller's question?
Useful in assessing nutritional education efforts. I think this process could probably be adapted to be used to assess any particular need. You just need to get the right people together and present the right data, the data that's relevant to that topic area, and have the right people there to discuss it. I believe it could be used for anything, behavioral health or nutritional education also.
Now you're surveying the general population in that phase two, um, and then you're taking that to decision makers. And how do they sort of engage your center in this process? Is it you know, and what are the kinds of turnouts you get, when you have these community meetings typically?
Oh, well, here's the way we typically do it because we're working with the hospital. The hospital administrator selects a small working group of about 6 people in the local community. We call it a steering committee. And that can be, typically we have the health department involved, maybe the chamber it doesn't all have to be health providers, just some local leaders. Those 6 people then sit down and they decide who they need to be, who needs to be at the meeting to represent the entire community. So they want all the health providers, you want the education system, you want the local government, county government, you want business owners, Main Street, etc., represented there. You want all your minority groups, you want some of your civic groups represented, and we really, and then that local steering committee makes all the contacts to the local people. We suggest in our toolkit, we suggest that they call them, ask them to attend the meetings first, then send a follow-up letter explaining what their role will be. And we have very little problem getting them because it's only 3 or 4 meetings a year at the most, And
Oh, yeah.
Yeah, I might.
How much are these
I'm
spread
back
out?
on.
we can do them as often as monthly on that first, the initial 3 or 4 meetings. We typically spread them out every 6 to 8 weeks. Gives us
Okay.
time, that gives the whoever's facilitating or preparing the products time to get those ready. We have a lot of reports to prepare and the community health survey results to do and so forth. So you need 6 to 8 weeks in between to get those reports ready.
Gerald, you're trying to get a word in there?
Yes, I'm finally back on.
Hi.
The thing that I find that really works is if you get them to that first meeting and you present the economic impact and go through what you're going to do with the survey and why you're doing it, you'll get tremendous attendance at the next 2 or 3 meetings. We never see a drop off in attendance, and I think that's because you are providing them data and you're asking sincerely for their input.
Good. Well, Dee had a question about how to get to the priorities.
That one, some people would use a voting technique. Now, we have that in our back pocket if it doesn't surface, but you let the local people kind of lead the discussion. And we have the flip charts up there where everything's listed, and they will start discussing among themselves, and before you know it, they say these are the top 3 or the top 5. If that doesn't appear to happen, you could do, I call it the sticky dot voting process. But they generally come up with their 3 to 5, and well, I never try and limit it to 3 or to a particular number. I just say come up with 3 to 5. Once in a while they may come up with 6, but that's fine. And with those priorities, of course, there's people saying we can do this, or here's how we can do this. So then it's easy to assign responsibility or attach responsibility to doing those particular issues.
Do you recall instances where mental health or substance abuse came up as one of the priority issues, and then what were some of the steps that they took to deal with those particular conditions?
The Kula one here, one of them was they did have some problems with mental health, and one of their priorities was to reduce the stigma of mental health issues. A lot of times in small rural communities, people don't, they don't want to admit they have mental health issues, or they're afraid to go to be seen going to mental health. And some of this is cultural. So some of their solutions were to work with the churches and the schools to get an educational programs out there about mental health and to reduce that stigma. So that was an example in this Kula report.
Excellent. I love Dee's comment. That's great. Any other questions from anybody else out there? There's a few of you on there.
I just saw Dee's comment, and I love it too.
Yeah. Well, this is a really interesting model, and I definitely see where some of these pieces would be useful for us as we move forward, thinking about how these pilot educational processes would go. So I appreciate your sharing this today.
Thank you, Scott.
You're welcome.
All right, great.